And the webinar is going to be recorded because we know that not everyone is going to be able to join us, and we also know that you will want this content for the future. We also want to acknowledge over the past weeks, we have seen communities mourn. We have mourned loss of innocent lives, George Floyd, Ahmaud Arbery, and Breonna Taylor, and the silent many who too have been victims of violence, but remain anonymous to the world. We have mourned the continued influences of racism and power as symptoms of violence against citizens of color. And we have mourned the consistent and centuries-old experience of injustice and fear. Sadness, fear, exhaustion, and rage are all emotions that have been captured in our cities and communities across the country and indeed the world. For your patients and clients, these are not new, but instead repeated feelings that are all too familiar. And as leaders in healthcare, we have an opportunity, an obligation to maximize the wellness of those that we see and treat. Part of this is reducing the long-standing and long-lasting trauma of violence and injustice. The work described in these webinars and done in our grant collaborative begins to address the disparate health-related social needs that create the conditions that can lead to violence. And it is our hope that with knowledge, skills, and resources, you will be able to continue to affect positive change in your communities, healing the deep wounds of oppression and inequity. And we really felt like it was important to make that context part of this discussion, as we know the world has really been shaped by a great deal of events over the past couple of weeks. So we hope that you carry that context with you as we continue these presentations. And without further ado, I do want to turn over the introductions and the presentation to Amy Vincent and her team at VCU Health's Injury and Violence Prevention Program. So I will turn it over to Amy to continue the presentation.
Thanks, Davis. Hi, my name is Amy Vincent, and I am the Assistant Director for the VCU Health Injury and Violence Prevention Program. Today you'll hear a little bit from me. You'll also be hearing from Dr. Abatanos as well. He unfortunately is going to join a little bit late, but the reason is actually very pertinent to what we're talking about today. He's actually just getting out of the OR treating a gunshot wound patient. So he will join us as soon as he's available. But Dr. Abatanos is the Chief and Division of Acute Care Surgical Services here at VCU Health, and he's also the Medical Director of VCU Trauma and our Injury and Violence Prevention Program. And then lastly, we have Rochelle Hunley, and I'm going to let Rochelle introduce herself. Rochelle, if you're speaking, you might be muted.
Hear me now? I'm sorry.
Yes,
Hello?
we can hear.
Sorry. Hi, good morning. My name is Rochelle Hunley, and I am the Bridging the Gap Emerging Leaders Program Manager.
So that is our team for the presentation today, and we'll give you a brief overview of our whole team at the end. If you can go to the next slide, Davis. So what we plan to talk about today, we plan to give you a brief overview of violence as an epidemic. We're going to look at some Virginia data and why that is important for hospitals and health systems to really understand. What is the role of the health system in terms of violence prevention? And then we're going to talk about hospital-based violence intervention and give you some context by sharing our own story of our program called Bridging the Gap. And then we'll also have time for question and answer. And as David said, please put your questions in the chat box. And I know that he will be reviewing those as we move along. And I believe I see Dr. Abatanos just joined, if he'd like to introduce himself, although he may have just popped on.
Yes, hello. Hi, sorry I'm a little bit late. Actually, I was in the OR with another gunshot wound, so very appropriate. But I'm Dr. Abatanos. I'm the Chief of Trauma and Acute Care Surgery at VCU. I'm the Director of the Injury and Violence Prevention Program. And it's really a privilege for me to be on this webinar because it's a very important topic. I'm sorry I'm a little bit late.
So we're going to start talking about violence as an epidemic disease. It's now become really clear, scientifically clear, that violence behaves like a contagious and epidemic disease. It meets the dictionary definition of disease, so looking at characteristics and signs that cause morbidity and mortality. But it also meets the definition of contagious, meaning that it's transmissible, causing more of itself. You know, the greatest predictor of violence is a preceding case of violence. Violence also exhibits the population and individual characteristics of contagious epidemics, meaning clustering, geotemporal spreading, and person-to-person transmission. But despite the fact that it's categorized as a disease, it's not primarily managed by the health sector and healthcare professionals. We are not the primary spokesperson on this issue in most circumstances, but healthcare professionals have an ethical responsibility to understand violence, to convey accurate information to patients, to their family members, and to the community, and to provide the best care and follow-up to ensure recovery from violence and to help prevent violence. Hospitals really provide a unique window of opportunity for violence prevention. We're interacting with patients at their most vulnerable, and most likely they're more willing to accept and receive the help that might be needed.
I can add to that, Amy. So I think it is true in what we have stated, but it does not mean it needs to be that way. And I think this is what we're going to show in the rest of the slide as we move forward, the need for a paradigm shift for the role of the health system, especially of the hospitals, in this disease. And it's very important. I think we have diverged the clinical from the social. We have applied significant amount of social aspect to our patients and other diseases, but in violence, and most of the time we have not as much unless we're fully integrated. And this is what we're going to show coming later. I think this is a really incredible slide because it shows many other aspects. So it's up to us where you want to tackle this disease. You want to tackle it at the bottom row where you have all these people, or you want to tackle it at the top row where you only just have the very first person who's been infected with a violence virus, let's put it that way, and can we interrupt at this level? And I'm not sure if Amy talked about it already or not, but as you will see, one thing we have found is that our patients who come to us, and they're in the bottom row, most of the time they've been in our health system before. And so this is a window of opportunity that Amy was talking about. And I'll submit to you, if every hospital that sees violence, go back, you'll find out that your path have crossed with that patient at a previous level. And we'll talk about that and how that influences how we change the paradigm of what is the role of the hospital in our community, especially of our level 1 trauma center. Go ahead, Amy, sorry.
No, we're good. Go to the next slide, please. So I'm going to turn this over to you, Dr. Abitanos. I know this is something that you're really passionate about, is talking about the numbers and how do we compare and how does this impact how we serve our patients?
Yeah, I think so. It's very important that when you look at trauma and injury in general, it will seem that the majority, as you know, are motor vehicle crashes or falls. That dominant and type of diseases that are present. And how do you compare to others? If you look at this map, for example, and you see smack in the middle, that is Richmond in the city. And then around it, we're looking at all the gun-related homicide. And this is from 2013 to 2017, 10-year expansion. And you see that all these various pockets where violence exists. So a big part is then how do we compare ourselves between when it comes to our community numbers, because that dictates what resources you're going to put. That dictates how does the health system respond to this community disease. And when we look at resources, everything is a priority. You have to prioritize, right? You can't take care of everything. But if violence is a major part, and for us, for example, when I look at the map, you see in Richmond, our numbers are very high. If we miss that, if we don't respond, then we're not adequately responding to what the community need is. And this has been obviously very highlighted lately as far as how are we responding to violence and with all its root causes. And so when you look at our numbers, and you can see here, for example, when we compare ourselves initially just with regard to Virginia and the national average, you see that our numbers are pretty comparable and with regard to the violence. So we're not a state that has lower numbers than the national average. But those numbers can fool you unless you look at the map and try to see, are there certain pockets where our numbers are higher? Another thing is very important. It's a big mistake when you're looking at what is the role of the health system in violence to only look at mortality. And because mortality is only a short answer to the big burden of disease that we have. That number, that picture we showed you before about how it's like a disease gets infected, any person who's involved with violence, that person now is a vector that can promote more and more violence. So what does that mean? You have to look at hospitalization due to gun-related non-fatal injuries, not just those that are involved with mortality, because that gives you a whole different picture about the burden of disease and about the role that you must play in both prevention and intervention. So the health system, we just cannot ignore this problem, especially when we look at the various numbers. Okay. When I go to the next, okay. So the other part is, like any disease, you have to dissect it. You have to find out, okay, who's affected the most, because that targets your intervention. And as you could tell from looking at gender and age, and gender male is a significant difference, especially in the when you look at the age distribution, and you find out when you're talking between age 10, 14 to about 44, with the peak being around between 20 and close to 25 here. For us in VCU, our peak is 27. And so if you're looking at your resources, you have to be able to target this population. If you're looking at prevention, if you're going to target everybody at age 27 or age 30, you're already too late. You got to look beyond where the age 10 to 14 is. And that influenced when we did our violence prevention program, what age bracket did we use? And the fact that we started at age 10 and on purpose in order to catch everybody under that curve. And then also you turn around and just say who's more affected and what's the ethnicity and what is race. And you could tell here, and we've had this highlighted, Black men are victims of gun-related homicide at a rate of 8 times that of Black women. But if you compare it to other white men, 11 times. So no matter how you feel about it, you just can't ignore this data. You cannot ignore that this is a significant problem and that this is your target. And then that influences honestly, when you put your program together and when the hospital engage in a community in any type of aspect of prevention and intervention. So if your hospital has violence and is involved and most of its targeted is white men, older age, you're targeting the wrong thing. You know, so this shows a significant issue that we have with regard to looking at trauma as, especially violence, as a disease, and then trying to figure out who's affected the most, how do you target your entire program, and how you engage the entire health system toward this issue. Okay. And so the other big aspect is when you look at your own area. So for us, if we came and said, yeah, your falls and your motor vehicle crashes are very high, and we have programs for those, you know, and we're heavily working with regard to those, that cannot be ignored. But if you look at the burden of disease when it comes to violence, and so look at the firearm death rate for Richmond, Virginia, when we compare ourselves to Virginia and then to the nation. So if we only have looked at Virginia by itself as a whole, you would have missed the significant difference in the death rate if you're in Richmond compared to the rest of the state or compared to the nation. And so these are pretty dramatic numbers, and the numbers have went down, as you see. Around, it was a huge epidemic and around basically 2003, 2004, down to 2008, but now since 2014, 15, we're starting to see this rise again that is present. And so if you cannot be a health system engaged in the community without being involved with this issue, especially where your rates are 4 to 7 times higher than the rest of the state or the nation.
So what does that leave us with? What is the role of the health system in violence prevention? And that's sort of what we're going to address for the remainder of this presentation. So in order to understand what the role is, you really need to understand risk factors using the social ecological model as a demonstrative tool. So what makes someone vulnerable to gun violence? Our ultimate goal is to stop violence before it begins, and we know prevention really requires understanding the factors that influence violence. The social ecological model, which I didn't put a picture of up here, it really considers the interplay between the individual, the relationship, community, and societal factors. It allows us to really understand what are the range of factors that put people at risk for violence, but what also protects them from experiencing or perpetrating violence as well. So this model suggests that really in order to prevent violence, you have to act across multiple levels at the same time. You can't just look at the individual without looking at the systems in place around them. So understanding that, you know, you have to look at their family, look at their peer and social risk factors, look at the community risk factors that are surrounding them as well. So if we're looking at the individual, it's really identifying the biological and personal history factors that increase someone's likelihood to become either a victim or a perpetrator of violence. Some of these things are history of violent victimization, treatment for emotional problems, high emotional distress, behavioral control. Prevention strategies at this level usually include, promoting attitudes, beliefs, and behaviors that prevent violence, and that might be conflict resolution, life skills training, things that we do in a hospital-based violence intervention program. So the relationship level includes both family risk factors and peer and social risk factors. It's looking at relationships that increase the risk of experiencing violence because we're looking at the person's social circle and those that they're closest to. So their peers, their partners, their family members, and how it influences their behavior. So some of the things that we look for are as someone was growing up. This could be, was there parental involvement? Was there attachment to parents and caregivers in a positive way? What about substance use within the household? If you're looking at peer and social risk factors, Are they associating with peers that are not participating in pro-social behaviors? Are they rejected by their peers? Do they have a commitment to school, and how are they doing when they are in school? Some of the strategies that we look at, again, go along the lines of problem-solving skills and building healthy relationships to help combat some of those risk factors. And then lastly, we really need to look at the community level as well. So this is looking at settings like schools, workplaces, and neighborhoods where social relationships occur. So we're looking at strategies that impact social and physical environment. So that might be reducing social isolation, improving economic and housing opportunities. It's also looking at, processes and policies and sort of the bigger picture. But these are all things that health systems can play a role in. We're not just looking at that clinical piece, and I would think most health systems across the state are doing a lot within their communities as well. And just to make one point clear is that risk factors are characteristics that are linked with youth violence or with violence in general, but they're not direct causes of violence. So we never want to assume that because someone may have experienced these types of risk factors that they will automatically become a victim or a perpetrator of violence. I'll go to the next slide. Thank you. I'm going to turn this over to Rochelle.
So as healthcare providers, we really should look to support our patients by establishing security and reducing the barriers that are blocking their access to adequate care. So we can first do that by looking at ourselves and improving our institutional systems, cultivating opportunities and creating access for our patients to participate in their care, establishing networks so that we are able to provide wraparound resources, and lastly, and I believe most importantly, establishing trust and demonstrating respect. Next slide, please. So as healthcare systems, we can no longer just solely focus on the clinical aspects of our patients' care. It is the hospital's obligation to respond to the needs of the patients as that their substance abuse, mental health, and in today's case, violence. And so how we're able to improve our institutional services is making sure that we're creating equitable environments for patients to thrive in. So that's making sure that all of our healthcare providers, clinical staff, and team that's serving our patients is coming from a very trauma-informed care that are operating through trauma, that they are trauma-informed. We're also making sure that we're regularly giving training so that folks are understanding of the population that they are serving. So specialized training. We're also improving our clinical and both clinical and social patient outcomes. So making sure that we're addressing the scarcities, whether that be food scarcity, transportation scarcity, working on addressing the scarcities that are contributing to the lack of success for their outcomes, looking at both clinical and social, helping with financial, improving personal and professional development for patients, which we'll go into later, and really looking at housing security. Next, we are emphasizing the importance of violence intervention and prevention initiatives in our health system. We have a whole team that focuses on intervention and prevention through our Bridging the Gap program and Project Empower Domestic and Intimate Partner Violence program. Next slide, please. So working with underserved populations requires a significant amount of care and expertise that our health system often does not have. This is why there's a great need to establish community resources and supports for our patients that are leaving our health systems. And so we are able to do that by increasing awareness of community-based resources to close our gaps. So with our team, we saw that our patients really needed mental health services, housing resources, and things to address the jobs and lack of income. And so looking at what community partners in Richmond could address those gaps. So building capacity for our patients, eliminating silos and maximizing our resources through our initiatives such as Inspire and RVA Alternative Pathways. We're able to communicate directly and establish relationships with our community partners that helps us to give the very best care possible to our patients. We also reduce the barriers that inhibit the involvement. That meaning looking at what are our patients' needs and what is prohibiting them from participating in our services and connecting with the community partners. Examples being transportation. So having bus tickets available and list services available to give our patients to our appointments. So that is just an example of how we reduce the barrier for them to participate in our programs and services. And lastly, helping patients to develop positive behaviors and attitudes. And so sometimes it is very hard for our patients to feel that their voices are being heard, and that in reality, when you are in such a traumatic situation, it's very hard sometimes to not feel numb. And so addressing trauma and making sure that patients have positive attitudes towards their health outcomes. Next slide, please. So as healthcare providers, we should aim to improve health outcomes of our patients. So having access to comprehensive and quality care services is important for promoting and maintaining health, preventing and managing health-related issues, and achieving health equity for all of our patients. We also facilitate opportunities to confront and address trauma. A lot of the time, mental health is a stigma, but it's also contributing to the violence that's going around. So creating opportunities to address and confront that trauma, especially generational trauma, has helped to improve our patients' health outcomes. And lastly, educating patients on personal behavior changes that influence greater change. And so we really do focus on making sure that patients understand that the behaviors that they are engaging in, whether that be substance abuse, violence, anger, that their behaviors is influencing their circumstances. And by making these little changes, we're able to slowly improve their health outcomes. So I think this is the most important thing, and I'm going to share a quote from Maya Angelou. She said, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." So how you treat a patient does go on to affect their health outcomes. That is why we must always be respectful to our patients, regardless of race, gender, sexual orientation, or socioeconomic status. Every patient deserves the same level of care. We must meet patients where they are and beware of the savior complex. So I'm always talking about the savior complex because we often get into this work because we want to help people and we have our own personal ideas of success and what we can do to change the world. And that's why it is beyond important to make sure that we meet our patients where they are and help them to achieve their ideas of success for themselves. And lastly, we must educate, engage, and empower patients to contribute to the change that they want to see. And so that is giving patients a voice in how they want their care and how they see their care being managed.
So the role of the health system also means we need to be talking about what does that mean internally and how can the health system be an advocate and support for these types of initiatives. So number one, having a strong program champion. This would be a decision maker in administration who really wants to push this as a priority for the hospital and health system. Without somebody at the top, it's hard to make those moves at the bottom. So having that champion really helps us to establish a program that is well respected within the health system. Internal groups. So you need to have people within different departments. So whether that's, a nurse in the emergency department, or even a care partner, or another physician who's going to push the merits of the program to their team members, to their colleagues, and back to organizational leadership to help support the needs of specifically a hospital-based violence intervention program, but even to support those initiatives that are just starting out. And then leadership. It's really leaning into their interest in the impact on the community and that the institution serves. Leadership is often the face within the community and is on the front lines when things come back into our health system. Institutional support is the key to success. This work can't be done without institutional support. So we've shown our own institutional support here, and actually I think a few of these people are on the phone, which again speaks merit and to the importance of really maintaining those relationships and fostering them within your own systems. So without the support of those people on the right-hand side of your screen, our program would not exist, or we would exist in a very limited manner. They cross all sections of leadership, so we're looking at the CEO of the health system, to the chief nursing officer, to the chief of health equity, and across the university, even in our own department. So our department administrator is a huge support of our program. We were provided seed money from the CEO 13 years ago that really allowed us to prove our need. And with that, we were able to show that patients needed more than what we were able to provide them before this. Treating and releasing, which we'll show in a later slide, wasn't working. So they allowed us to start with a half-time FTE. That grew to a full FTE, which has grown to 2 FTEs. And today, with the assistance of VHHA especially, and with the support of our leadership, we've grown to have 6 full-time employees that are working to combat gun violence within our community and within our health system.
Yeah, if I could add to that, I guess I can't not comment on this slide, only because it is like as we're helping other programs also start, I'm always stressing this point. It is incredible. You have no idea who in your health system and how many are actually incredible advocate and supporter of the program, but you have to bring them to that level. There has to be some homework that's being done. You have to use the data, both internal and external, to advocate as to why your own hospital, your own institution needs to support and need to be engaged in this disease of violence. So, and then you'll find out once they're engaged, they're way beyond you in their capability. They're way beyond you in their ability to help the program move it to a different level, to engage it at every level, whether it's on the nursing level or on the physician resident. Then it goes even beyond that. How do we engage in the community? There's so much already network beyond violence that's present within your health system. Once you have your health system infected with a different kind of a virus, this is the infected with the fact that we can combat this disease. There are certain ways to actually be very influential. You change the paradigm of what is the role of the health system in the institution. That is the most important part, and you cannot do it without these leaders in your own health system. And they're phenomenal leaders in all aspects. I cannot stress more than what Amy have said. I get the accolade, hey, look, you've done a great program, but I'm very aware that we're very small, standing on shoulders of these giants, and these giants exist in all your health systems. And so they just want you to be able to advocate and just say, this is what we need from you, and this is the reason why, and these are the results that you were able to get. And we'll kind of talk a little bit more with regard to our program afterward. But I cannot stress how important institutional support is, and you have to be aligned with what is the role of your institution in the community. Then you could slowly start helping move that needle with regard to the understanding of the disease. And so It is a very, very, very important. I call that the first step into community engagement is your own institutional engagement. Then you could take off after that.
We're going to talk a little bit about hospital-based violence intervention programs. I think this is one way that health systems can really make a difference within their community and those that surround them. So hospital-based violence intervention programs, or HVIPs, they're really multidisciplinary programs that bring hospital staff, trusted community-based partners together to provide safety planning, wraparound services, and trauma-informed care to violently injured patients. It's really engaging patients within the hospital during their recovery. That's the golden opportunity to improve their lives and reduce retaliation and recidivism, and also mortality. And this is what I was saying, hospitals provide that unique window of opportunity. And an HVIP is not just helping the patient. So what we do in our own programs is we connect the case manager to the patient and their family. And family can mean a lot of different things. Family can mean, you know, blood relation, but it can also be their peers and their friends that really are there to support them, their support system. And we connect them to the resources that are going to help them to succeed with the goals that they have set for themselves. So this is connecting them into community resources like connecting them maybe back into the school system, helping them to get their GED, connecting them to workers' comp, to legal advocacy, housing, medical assistance. It's creating these community ties and creating those warm handoffs between the case manager and the community service provider so that we're making the path a little bit easier for that patient and family to navigate. So why is this important? Before we had a program like this within even our own hospital system, we were treating, releasing, and treating again. The hospital system becomes a revolving door for violent injuries. But we have a larger role to play. We can't fix every problem, but we are one piece to the larger puzzle. The 5-year re-injury rate for victims of intentional injury is between 10 and 50%. And 10 is very low. We know it's probably closer to 50% for those that are being violently injured. We know 20% of those that are violently injured are estimated to die as a result of subsequent violence. So you're treating somebody and releasing them back into the community, they're 20% more likely to come back through your doors again. Even within our own health system, for those that are not involved within our Bridging the Gap program, we see through our trauma registry data, we have about a 15% re-injury rate. And just to give you the full picture, we see about 4,300 trauma admissions per year, and about 12% of those are firearm and stabbing. So we have a great program that we've been operating for about 13 years now, which we're really proud of. It's called Bridging the Gap. And Bridging the Gap is a hospital-based and community-integrated program that seeks to reduce violence through intensive case management at the bedside, but also continuing that intensive case management once the patient is discharged. And we work in direct partnership with our community resources to help clients address the disparities that contribute to the violent incident that brought them in. So Bridging the Gap, what makes this work? What is the science behind it? What makes this evidence-based? So we did a pilot study we completed in 2011, and we're currently doing a full evaluation as well. But what we know is that this is an evidence-based program. We know that people who come into the hospital and receive brief violence intervention at the bedside, combined with intensive community-based case management, have better outcomes than those who only receive brief violence intervention at the bedside without any follow-up or without intensive community case management. we've seen this, we've been able to prove that this works. It's important to realize that without that intensive community case management, we're still missing the mark, which is why we do intensive case management at the bedside and continue for up to a year with our patients within the community system.
And so Bridging the Gap offers several different, there are several different components to Bridging the Gap. The first one being that we've implemented that every patient that enters our hospital, regardless of them meeting the eligibility requirements for Bridging the Gap, gets the standard of care. And the standard of care essentially is a brief violence awareness where we walk the patient through the incident, talk about how their behaviors contributed to the incident, what they could have done differently to prevent the incident, talking about coping skills and identifying supports in the community for them, and then offering resources. So every patient, regardless of them meeting eligibility requirements, receives the standard of care if they were violently injured. The intervention at the bedside is where all of our patients that meet eligibility requirements, which at this time is that they live in the greater Richmond area. So Richmond, Henrico County, Chesterfield County, Colonial Heights / Petersburg area in the city of Richmond. So location. Secondly, if they're between the ages of 10 to 30. Third, if they are a victim of an intentional injury. At this time, we are not seeing any self-inflicted gunshot wound patients. And if they're if their injury was not related to domestic violence or intimate partner violence, we do have Project Empower, which addresses those needs. So right at this time, if you fall into that eligibility, you will receive intervention at the bedside, and that consists of a case manager consistently rounding as the patient is admitted, visiting them daily, and providing them support in the hospital. We assess the patient similar to the standard of care. We talk about the incident, identify supports and coping skills for that patient, make referrals out to community partners to address some of those needs, and also create a service plan to help our patients achieve the goals they want for themselves. It's intensive case management for up to a year, but oftentimes it's longer than that, or sometimes shorter. And so that program, our intervention at the bedside, offers intensive case management and support for our patients in the hospital, but also in the community once they're discharged. Lastly, we have an Emerging Leaders Program, which is our youth violence prevention program. And so what we were seeing was that our Bridging the Gap patients had been into our health system 2 to 3 times prior to coming back and being in a more serious situation. So they were coming through our ED, whether that meaning they were in a fight in school or a bullet grazed them and they were treated or released, before they came back in and were shot in the chest or shot in the head and had more severe injuries. And so we were saying, well, could we have done something prior to them having that more severe injury to prevent it from happening? And so thus Emerging Leaders was created. It has also been a way to help the family, since we do provide wraparound supports. And so what we were also seeing was that younger siblings, younger friends of the family were starting to exhibit some of these violent behaviors. And so could we do something before they ended up like their siblings or their friends? And so Emerging Leaders is essentially the prevention part of Bridging the Gap, where we still do the intensive case management and offer groups for youth.
And Davis, can you? Oh, I'm sorry. Go ahead, Rochelle.
Oh, no, sorry. I didn't realize it was, okay, sorry. No, you can
Yeah, we were behind in the slides. I just wanted to make sure we caught up.
Okay, so like I was talking a little bit about earlier, the standard of care is offered to all of our patients and consists of the BVA, which is our assessment tool, where we are looking at the factors contributing to the violence, and then also giving resources for folks so that they are able to get the support that they need. I'm sorry. So this is intervention at the bedside. So where we are building relationships with our patients. And so in the hospital, whether they're admitted for 2 days or 10 days, a case manager is at the bedside with them every day, checking in on their family, acting as an advocate in the hospital as needed. We provide the case management resources for up to a year, connecting our participants and their families with community supports and resources. And lastly, like I said, we track recidivism. After the year, we track recidivism and such. So our Emerging Leaders program was really developed to address those risk and protective factors that Amy was talking about earlier. We aim to prevent youth violence by increasing protective factors and decreasing risk factors and overall improving access to healthcare for these patients. And so we're able to do this by having the community case management, creating opportunities for youth. So through our Emerging Leaders program, we're able to expose them to healthcare careers through our paid summer internship programs, and also connecting them post-grad to our health systems employment program, and then also working with our partners to introduce youth to diverse learning experiences.
So what is the effect of community-based intervention when it's supplemented with hospital-based brief violence intervention? So what we saw when we conducted our pilot study was that the VCU health system, in partnership with the Richmond community, we saw a reduction in recidivism from 15% to 3.6. So this was for participants that were enrolled in the Bridging the Gap services that were intensive case management at the bedside, followed up by that intensive community case management. We saw a reduction with short-term risk factors. So our patients were 2.5 times less likely to use alcohol, and there was also a significant reduction in drug use as well. We saw our hospital service utilization change too. So our clinic visits actually increased. Before this, there were a lot of challenges with getting our gunshot wound patients in particular to come back for follow-up visits. This made them 3.5 times more likely to schedule those and to actually show up. And then we also increased our patients' idea of how to appropriately use the ED. Instead of using the emergency department to help treat the wounds that they had, we encouraged them to go to the clinic visits and to see their primary physician that was treating them. And then lastly, community service utilization. Patients were 2.5 to 3 times more likely to use community services at 6 weeks and 6 months respectively, and about 90% connected to community services within 6 months. And that's a pretty huge jump from where we had been.
Yeah, I'm going to add to that, Amy. I think this is an incredibly important slide. This is what your hospitals need to see. You cannot, it was easy for me to tell you earlier, you have to engage the hospital and the hospital leadership specifically. But there's different ways of engaging them. It's how do you engage them? And not simply talking about the emotions and your social responsibility. All these are important, but you also have to talk about the bottom line. And this is what this is our ability to show, like Amy mentioned, that our usual patients were involved in violence. Maybe 60% when we looked at our numbers actually show up to the clinic visit. They're all no-shows. That's very costly. I could have put in somebody else in that clinic that can bring benefit to the hospital, as an example. And so the idea, our ability to improve the clinic visit to up to 90% if you're in our program is a huge deal. And so now suddenly you have your hospital administrators looking at this very differently. Our ability to reduce our ED volume by very inappropriate visits, people coming back just for pain medications or for other things that can be dealt with very easily in the clinic or by calls, etc. And so the patient is not felt abandoned. The program holds the patient together, and then the hospital is seen as a partner now with regard to this. So the hospital service utilization is incredibly important as you approach as any health system, especially in a health system, to say why you need to be engaged in violence. It makes a difference when you do. And then, like what Amy said, then the community service utilization. What is the role of your hospital? This is when your hospital can take this as they're engaging whether it's the governor or the mayor's office or the AG office, you name it. They have with them a tool. This is what we are doing. This is how much we are engaged into getting those patients appropriately connected with these community services. So this is the data that I spoke about before. The ability to have your hospital engaged or your entire health system engaged is based on the fact that you could deliver, especially if you use evidence-based programs, which what we have put together. I will submit this is not routine things that any hospital does. This is incredibly unique, but it's a formula that can be used in other places. It doesn't have to be isolated to only one hospital that does this. And so that's why we're incredibly grateful to VHHA and our ability to expand the program. Something else I was going to mention that was a little bit missed, I thought Amy would talk a little bit more about that, is when we talk about advocacy, it's the advocacy to also get funds to these type of programs in the community. That becomes extremely important. So Amy, maybe you could mention very quickly how you play the role in advocacy for us to be able to have these incredible funds that are supporting the programs across the state.
Well, I think it's having a voice and making the right connections to, it was making connections within VHHA. It was making actually connections also within the health system as well to get to that point. It's being part of community collaborations as well. So we are part of a group called the Inspire Work Group, which is a group of about 45 community partners that come to the table to talk about how do we reduce youth violence in the city of Richmond. So we've been able to, procure grant funding through that as well to help us build our program. It's really creating those relationships with your community partners, with your healthcare associations, with the even your local philanthropic organizations or community foundations that are going to help propel you forward. And that's something that we've done over the last decade, is make and build and continue to build those positive relationships. So we really encourage you to connect with us. If you have questions, if there are things that came up today that you want more information about, please feel free to reach out to anyone on our team. Dr. Abitanos, myself, Rochelle. I also included Ashley Xavier on here because she's also been a really fantastic team member to make connections with. We are here to help you figure out what it might be that you could use, what information you could use to help build a program within your own hospital system. And I'd like to introduce you to the rest of our team as well. So this is the rest of our Bridging the Gap team, which we are very, very lucky to have. Without them, we wouldn't be where we are today. I know we're right up to the 1 o'clock mark, so I don't want to take up too much time, but I did want to make sure that you got to see their faces, as they are the boots on the ground and they are the face of our program.
Great, thanks, Amy, so much for a information-packed presentation. So much great information and so much great action steps that our partners and our participants can take. I know that we are at 1 o'clock, and I know many of you probably have places to be, but I did want to mention that, like I said at the beginning of this presentation, this is the kickoff of Gun Violence Awareness Month. Their VHHA Foundation and its partners in the collaborative are doing a ton of work around this to raise awareness for gun violence prevention and to work towards preventing gun violence. I will be sending out a follow-up email to this webinar series that will include more information about things that you can do. But I will mention on June 5th is is National Gun Violence Awareness Day. So please wear orange for that. And we'll have more information about that as well. If you're interested, I'll leave this slide up as we leave. But I do, we don't have any questions in the chat. It doesn't appear as we're at time, but I did want to say thank you all to all of our presenters in the past: Bonnie Price, Ruth Mecklem, Amy Vincent, Dr. Abitanos, Rochelle Hunley, all of you for giving us the great information and all the expertise that you have given to us, and that will continue to transform the lives of survivors in the Commonwealth. And I want to thank you all as participants for your commitment to your patients and the commitment to progress. I really feel good about the direction that we're going and your commitment to the betterment of your patients and your communities. Sorry for running over, but I really feel great about the information that was given, and I really hope that across the webinars this time that you are able to take some things away and apply them to your own health systems and your own organizations. They will be posted on VHHA Foundation's website. Please look for them, watch them. If you missed anything, share them, please, with those that were unable to join us. And we look forward to future participation. Thank you so much, and I will be in touch with follow-up information. Thank you all so much.